I'm Dr. Hrishikesh Joshi, Associate Professor in Obst.Gyn. Today my topic for discussion is anemia in the pregnancy. Now, the anemia in the pregnancy I would like to discuss under the following heads. The first is definition of anemia. Now, what is anemia in the pregnancy? Anemia is the most common problem encountered during the pregnancy. Now, how to define anemia? Anemia is defined as decrease in the oxygen carrying capacity of blood due to decrease in the amount of the red blood cells or the hemoglobin or both. Now, what is physiological anemia in the pregnancy? There is physiological hemodilution in the pregnancy leading to fall in the hemoglobin. There is 2.5 to 3 times increase in the plasma volume as compared to RBC mass. Maximum increase occurs in the second trimester of the pregnancy. Now, what are the criteria to call it as a physiological anemia? The hemoglobin is 10 gram %, RBC count is 3.2 billion, the PCV is 30%, per speculum examination, peripheral smear examination, normal morphology of the RBCs with central pallor. Now, how to classify the anemias? Anemia are classified into mild, moderate, and severe type, which are as per the grading of the hemoglobin present in blood. The main type of the anemia to be discussed are iron deficiency anemia and the megaloblastic anemia. Now, the classification is physiological anemia of the pregnancy, and second is the pathological. Pathological, the first is deficiency anemia, which is iron deficiency, folic acid deficiency, vitamin B12 deficiency, and protein deficiency. Second is hemorrhagic type, which is acute following the bleeding in the early months and antepartum hemorrhage. Chronic is hook or infestation and bleeding piles. Third is hereditary, which is thalassemia, sickle cell hemoglobinopathies, other hemoglobinopathies, and hereditary hemolytic anemias. Then the fourth type is bone marrow insufficiency, which is hypoplasia or aplasia due to radiation or drugs, which are aspirin and indomethacin. Then comes the anemia of the infection, which occurs due to malaria or tuberculosis. And the last is chronic diseases like renal disease or any presence of neoplasms. Now, iron deficiency anemia. So, iron deficiency anemia, it is considered as a nutritional type of anemia, and in India, 90% of the anemias are of nutritional origin. Now, iron deficiency anemia, the causes are: first is low iron intake. Low iron intake, as iron cannot be produced in the body. It is essential to eat food which are rich in iron. So, cooking in iron utensils is helpful. Apart from the socioeconomic factors, the faulty dietary habits, loss of appetite, and the vomiting in the pregnancy are other contributing factors. Then dietary sources are vegetarian and non-vegetarian. So the main dietary sources are green leafy vegetables, cereals, pulses, fruits and others like jaggery and dates. The non-vegetarian are liver, meat, fish, egg are the medium sources. Now the second cause is increased nutrient demand. So each pregnancy needs 1 gram extra iron, and most of it is required in the second half of the pregnancy. Although iron absorption increases in the pregnancy, which is 20 to 30%, the average vegetarian diets don't contain enough iron to meet this demand. So, saving of iron in the period of amenorrhea is utilized during delivery. The third factor is poor absorption and utilization. Now, what are the inhibitors and enhancers? Inhibitors of the iron absorption are phytates in the cereals, tannins in tea, polyphenols in the coffee, then oxalates in the vegetables, phosphates in egg yolk, and proteins. And what are the enhancers or stimulants of iron absorption? The first is vitamin C. Second is citric acid, lactic acid, sprouted and fermented food, and meat and fish. Now the next factor in iron deficiency anemia is the poor iron reserve. So what are the normal iron stores? It is 300 to 500 milligrams. Then due to hookworm infestation and Necator americans infection, the iron loss occurs. Then in the Paris women, repeated pregnancies at short intervals of less than 2 years and prolonged lactation leads to depletion of iron stores. Then increased loss. It occurs in cases of malaria and hookworm infestation. Excess menstrual loss before the pregnancy and sweating are also responsible. Now what are the clinical features of iron deficiency anemia? We will study this into symptoms and signs. Now what are the symptoms? First is fatigue, lassitude, weakness and impaired work capacity. Second is dizziness, giddiness, headache and insomnia. Third is dyspnea on exertion, palpitation, anorexia and dyspepsia. And fourth is ankle edema. Now what are the signs? The first is the pallor of the skin, then the pallor of the mucous membrane. In case of this severe anemia, there is loss of the color of the palmar creases. Second is glossitis, stomatitis, and dysphagia. Third is koinonia, and the fourth is tachycardia. Then the next is crepitations. They may be heard at the base of the lungs due to congestion, and edema of the legs due to hypoproteinemia or associated preeclampsia. Now, what are the causes of increased iron deficiency anemia or anemia in tropics? First is poultry dietary absorption. then faulty dietary habits and iron loss. Now what are the effects of anemia on the pregnancy? They can be considered through maternal and the fetal. Now the maternal effects during the pregnancy are increased susceptibility to infection. Into bracket you can write intercurrent infection. Second is preeclampsia due to malnutrition. Then the next is cardiac failure at 30 to 34 weeks, and the fourth one is the preterm labor, which is 3 times at high risk. Then what happens during the labor? First is uterine inertia. Second is the postpartum hemorrhage. Even moderate blood loss can lead to collapse. Third is a cardiac failure, and the fourth is shock. In the periphery, what happens? The first is the cardiac failure. Second, peripheral sepsis. The third is subinvolution of the uterus. Fourth, failing lactation. Fifth, chronic ill health or a backache. Sixth, the peripheral venous the thrombosis and pulmonary embolism. Now what happens in the fetus? First is prematurity, then low birth weight baby. Second is IUGR. IUGR is at risk of 3 times more than the increased risk. Third is increased perinatal deaths, and the fourth is decreased iron stores in the neonate. Now regarding the diagnosis, first is diagnosis and degree of the anemia. So the RBC count is at least less than 3.2 millions, and PCB is less than 30% to call it anemia. Now what are the type of anemia? On the peripheral smear, the findings are: first is microcytic hypochromic type. Second is RBCs are small in size with the central papilla. Then there are features of anisocytosis and poikilocytosis. Then in the peripheral smear, it helps in diagnosis of malarial parasite. The reticulocyte count may be slightly raised, and occasional target cells may be present. Now what are hematological indices? There is decreased MCV, MCH and MCHC. Then the total iron binding capacity is raised. Then there are decreased serum iron and serum ferritin levels. Now how to manage the iron deficiency anemia? So management, it can be discussed under 2 heads: the prevention and treatment. Now the general preventive measures are: First, fortification of the food by iron. At least 30 milligram of iron to be added per kg to the wheat flour. Second is the fortification of the common salt by iron. Third, screening of adolescent girls in schools and giving iron supplements. Fourth is education and motivation about the intake of the diet rich in iron. Next is the change of the food habits to avoid tea or coffee at least 2 hours after meals. Next point is to prevent the hookworm and malaria infection. Next is to keep adequate interval between the two pregnancies for at least of 2 years and between the two pregnancies. Then next point is cooking in iron utensils is helpful. And the last point is early detection of falling the hemoglobin levels is to be made. And hemoglobin level estimation is at the first antenatal visits, then at 30 weeks, and the next one at least 36 weeks. Then the curative factors are, if iron levels are less than 9 gram per cent, admit for investigations and treatment. So due to high prevalence of anemia and inadequate hospital beds, if hemoglobin is less than 7.5, the patient needs to be hospitalized, and associated Obst.Gyn medical complications even with moderate degree of the anemia. Now, what is general treatment? First is diet intake, which is rich in proteins, ions, vitamins, which is easily assimilable. Second, to improve the appetite and to facilitate the digestion, preparation containing acid pepsin, TID daily after meals. Eradicate minimal septic focus, and fourth is effective therapy to cure disease contributing to the cause of anemia. Now, what is specific therapy? Specific therapy, the principles are to raise the hemoglobin levels as near to the normal. Then to restore iron reserve at least in part if possible before patient goes into labor. Now I will talk about the actual treatment, which is oral iron therapy and parenteral iron therapy. Now, what is oral iron therapy? Oral iron therapy is indicated in all mild and moderate iron deficiency cases. It is cheap, effective, at least 100 to 200 milligram of elemental iron is recommended. The ferrous salts are 3 times the readily absorbed than the ferric ones. The ferrous sulfate is the cheapest and well absorbed form of iron, where the iron content is 60 milligram in 200 milligram tablet. The other salts available are ferrous gluconate and ferrous fumarate. Then one more thing is new gastric delivery system which contains ferrous sulfate in the gel forming polymer matrix, so the tablet floats in stomach for 5 to 12 hours and releases a small amount to the absorptive area, which is duodenum, and it is claimed more effective as there are minimal or no side effects. Now, what is carbonyl ion? It is easily absorbed, less toxic than the ionized forms like iron sulfate. It has a high safety range. Now, how to start the iron prescription? Start with 1 tablet daily and gradually increase the dose, but don't give for more than 2 tablets a day. The tablet is to be taken with the meal, as before the meal it can cause side effects, and after the meal the absorption is decreased by 5%. Then avoid your coffee for at least 2 hours after taking the tablet. Folic acid supplements can be given in dose of 0.5 milligram. Also, vitamin C enhances iron absorption. The calcium salts, except calcium carbonate and calcium citrate, they can be recommended, but the other calcium salts are to be avoided. Now, how will you know the wellness of the patient is feeling well? First is the reticulocyte count. It increases by 7 to 10 days, and the hemoglobin rise occurs after 10 to 14 days. Now, what are the side effects of oral iron? Upper GIT, nausea, gastric discomfort, loss of appetite, and loss of appetite. Then lower GIT, diarrhea, constipation, flatulence, and staining of teeth. Now, what is parenteral iron therapy? See, one general indication that the parenteral iron therapy is started when patients are unable to take oral iron. So, what are these conditions? So, indications are: first is intolerance to oral iron, second, non-compliance to oral iron, third, poor absorption of oral iron, fourth, no response to oral iron after 4 weeks. Then next is some cases of moderate or severe anemia, which come very late in the pregnancy. These are some of the indications. Now, what are the injectable iron preparations? These are iron dextran injections, and second is iron sorbitol citric acid complex. Now, what is the other parenteral ions are intramuscular iron and intravenous iron. So, intramuscular iron, the 0.5 ml, the test dose has to be given initially. Then 100 milligram per day is given daily or on alternate day. That is 75 milligram the object offer. The injections are given deep intramuscular or by Z technique. Side effects of the injections are painful, then there is a discoloration of the skin, and it can cause injection abscess. Now, intravenous therapy, where the calculation of of the dose is done as 0.66 into the percent deficit of the hemoglobin into weight in the kg equal to milligram of iron, which take care of the stores, but 500 milligrams should be added for the pregnancy. Second is 25%, 25 into the percent deficit of the hemoglobin, which is equal to milligram of iron, and to this 50% has to be added for stores. Now, so for the procedures, you have to call the patient early in the morning. Then required iron is mixed in 500 ml of 0.9% saline. The requirement of iron more than 50 ml, where 1 ml is equal to 50 milligram of the elemental iron. So total dose is given on 2 consecutive days, or half the amount is given each day. Now what are the complications are? First is the thrombophlebitis. Second, malaise, fever, then arthralgia, urticaria, lymphadenopathy, and anaphylaxis. And advantages over the intramuscular are, so the intravenous injections are less painful. Second, the compliance is better, and the third is short hospital stay. Now, what is the role of the blood transfusion in the anemia? First, to correct the anemia due to the blood loss and combat postpartum hemorrhage. Second, patients with severe anemia in later months of the pregnancy. And the intention is to improve the anemic state and oxygen carrying capacity of blood before the patient goes into labor. Then to correct anemia and make the patient fit to withstand the labor stress and the blood loss following delivery. Then next indication is refractory anemia, and the last indication associated infections. Now, what is the quality and quantity of the blood used in anemia? Fresh blood or a packed can be given. So the quantity is 80 to 100 ml at a time, and transfusion should not be repeated within 24 hours. Now, what are advantages of the blood transfusion? First is it increases oxygen carrying capacity of blood. Second, hemoglobin from the hemorrhage red cells may be utilized for formation of the new red cells. Third, stimulation of erythropoiesis. Fourth, it supplies the natural constituents of blood. And fifth is improvement of the improvement is to be expected after 3 days. Now, what are the precautions to be taken in the blood transfusion? First, antihistaminic like the phenergan is to be given intramuscular. Second, use of diuretics to prevent volume overload, and also to produce the negative fluid balance, and observe the pulse, observe the respiratory rate, and look for any crepitations. Now, what are drawbacks of the blood transfusion? First is preterm labor. Second, increased chance of the cardiac failure and pulmonary edema. And third, the features of transfusion reaction. Now, what care to be taken during the labor? The first stage, lie in position, make her comfortable. Second is oxygen inhalation. So arrangement of oxygen is to be made. Third, strict asepsis to decrease the peripheral infections. Second stage of labor, to cut short the second stage by use of low forceps application or vacuum delivery. Then IV methergin 0.2 milligram, the following delivery of the anterior shoulder. In stage 3, you have to remain vigilant and avoid overloading of the heart. Then in the peripherum, what to do? In the peripherum, you have to do prophylactic antibiotics to prevent infection. Then second is pre-delivery anti-anemic therapy to be continued till patient restores her normal values. And third, the patient should be warned of danger of recurrence in subsequent pregnancies. Now, the word about megaloblastic anemia. Megaloblastic anemia, it is common in temperate climate. Second, the nutritional megaloblastic anemia, the tropical nutritional anemia. Third is Addisonian pernicious anemia, and fourth is the megaloblastic anemia of malabsorption syndrome. Now, what are the causes are? First is inadequate intake, which can occur due to nausea, vomiting, the dietary deficiencies, and excess cooking effects. Which leads to loss of vitamins and lack of raw food. Second is increased demand, which occurs due to increased maternal tissue, including red cell volume, and development of. Second is developing the product of conception. So, the folic acid in the non-pregnant state is 50 to 100 micrograms per day. And in the pregnancy, the requirements are 400 micrograms per day. Third is diminished absorption due to intestinal malabsorption syndrome. Fourth is abnormal demand. Abnormal demand occurs in twins. Then second is the infections will decrease the lifespan of the red blood cells. Then the hemorrhagic states like peptic ulcer, hookworm infestation. Then the failure of utilization, anticonvulsants used in epilepsy or in the presence of infection. The diminished storage occurs in hepatic disorders, vitamin C deficiency. So absorption and storage. Folic acid is mainly absorbed from the proximal jejunum in circulation, free or loosely bound to plasma proteins. Liver is main storage depot, it stores about folic acid. The clinical features are anemia develops in the late pregnancy or in the early puerperium. Then folic acid deficiency anemia. Now how to diagnose it? On the peripheral smear, macrocytic anemia is seen, hematocrit is reduced, MCV is raised, MCH is raised, then the MCH is normal, plasma folate and IBC folate are reduced, which show HB of less than 10, MCV more than 100 cubic micrometers, MCH more than 33 micrograms. Serum ion, it can be normal or raised. Total ion binding capacity is decreased. The serum folate levels are less than 3 and the vitamin B12 levels are less than 90. Standard criteria for diagnosis are at least 2 of the following features must be present. More than 4% of the neutrophils must have more than 5 lobes. Second is presence of orthochromic macrocytes. Then the presence of nucleated RBCs. Then the presence of the Hoyle-Joly body. The presence of the Hoyle-Joly bodies. Then presence of macropolycytes and features of macrocytosis and isocytosis. Now, what are the effects on the pregnancy? It was believed to cause placental abruption, spontaneous abruption, and the IGR. But the definition of folic acid has not been exactly proved these things. Now, what are the complications? First is abortion. Second is dysmaturity. Third is prematurity. Fourth is abruption of placenta, and the fifth is fetal malformations like hair lip, cleft lip, and the neural tube defects. So there is a definite association between the preconceptional folic acid deficiency and the neural tube defects. Now the management of folic acid deficiency anemia. First is the prophylaxis. Along with the folic iron, the folic acid is also recommended in the pregnancy. To prevent neural tube defects, it should be started at least 3 months earlier or preconceptional in the dose of 5 mg per day. What is the curative treatment? Specific therapy recommendation of the folic acid should be given for at least 4 weeks following delivery. Supplementation with 1 mg folic acid along with iron and nutritious diet can improve megaloblastic anemia in 7 to 10 days. Then how to respond? How is the response seen? First is sense of the well-being and increased appetite. Second, increase the reticulocyte, leukocyte, and the thrombocyte count. Third is rise in the hemoglobin levels. The folic acid should not be given without supplemental iron. So iron, vitamin B12, 100 micrograms on alternate days can be given if folic acid dose is not adequate. Vitamin C 100 mg is considered to be enhancer of the folic acid. Now, just a word about vitamin B12 deficiency anemia. Its deficiency is not common, as the requirement is very less. Secondly, in the pregnancy it can occur in case of strict vegetarians. Third, the common dietary sources are meat, fish, poultry, and dairy products. Fourth, vitamin B12 is absorbed in the ileum and it is bound to the intrinsic factor. The daily requirement is 2.2 microgram in the pregnancy and 2.6 microgram in lactation. And all the complications are similar to folic acid deficiency anemia. The treatment is oral preparation. It is unreliable, and for so injection midway can be given 1000 microgram intravascular once a week, and recommended for 6 to 8 weeks. Thank you.